When a patient presents with sudden onset confusion, a high fever, and focal seizures, the central nervous system has begun to short-circuit. You have a very narrow window to intervene before permanent structural damage occurs. The immediate diagnostic challenge is filtering through dozens of overlapping etiologies. Bacterial meningitis, autoimmune conditions, and systemic infections all trigger bizarre behavior and high temperatures, making the initial presentation highly ambiguous. Within this ambiguous matrix, the most time-critical suspect is herpes simplex encephalitis, or HSV. This aggressive viral assault moves rapidly from initial infection to irreversible brain death. Confirmation requires direct evidence from the cerebrospinal fluid. You must perform a lumbar puncture to sample the chemical environment directly bathing the brain. This table contrasts a normal cerebrospinal fluid profile against the signature of an HSV infection. While a healthy baseline shows minimal cells, the viral infection triggers severe lymphocytic pleocytosis and a highly specific spike in erythrocytes. The presence of these erythrocytes in the fluid proves the virus has infiltrated the parenchyma and is actively causing hemorrhagic necrosis within the temporal lobe. Identifying that erythrocyte marker in the fluid dictates the entire trajectory of the patient's survival. It is the dividing line between a curable viral infection and the permanent loss of cognitive function. Despite the rapid progression of HSV, clinicians frequently fall into a fatal procedural trap, waiting for PCR confirmation or definitive neuroimaging before initiating therapy. By the time imaging clearly confirms the diagnosis, the window for preservation has closed. The bright unilateral hyperintensity shown in the temporal lobe on this T2-weighted MRI represents severe hemorrhagic necrosis. The tissue is dead. Delaying treatment to obtain definitive visual or genetic proof guarantees the irreversible loss of brain parenchyma. You cannot afford to wait for the laboratory to confirm what the clinical picture already indicates. The standard of care mandates a strict protocol. The moment clinical suspicion aligns with the initial cellular findings in the CSF, you must initiate aggressive empiric intravenous acyclovir. Consider a patient arriving with fever and bizarre behavior, with a rapid CSF return showing 150 red blood cells and 80 lymphocytes. You face an immediate management decision. Sending the patient to the MRI scanner delays therapy. Waiting overnight for the PCR results is fatal. And hanging IV ceftriaxone will only neutralize bacterial threats, leaving the herpes virus entirely unchecked as it destroys the temporal lobe. In neuroinfectious emergencies, absolute diagnostic certainty is a dangerous luxury. Immediate empirical intervention with acyclovir is the only acceptable path forward. To find the source of other severe altered mental states, we must shift our geographic focus from the brain to the kidneys. When chronic kidney disease severely compromises the organ's natural filtration, toxic metabolic waste backs up into the bloodstream, generating profound neurological deficits. In patients with compromised renal function, you must quickly differentiate between two primary overlapping suspects, uremic encephalopathy and cefepime neurotoxicity. Uremia develops when the kidneys fail to clear urea and other organic toxins. These compounds accumulate in the blood, eventually crossing the blood-brain barrier and severely depressing central nervous system function. You can identify uremia through distinct physical markers. Look for asterexis, a rapid, flapping tremor of the hands when the wrists are extended, often accompanied by a grating pericardial friction rub auscultated directly over the heart. These external physical signs correlate directly to a critical internal data point. A blood urea nitrogen, or BUN level, surging well beyond 100 milligrams per deciliter confirms the clinical picture of uremic poisoning. You cannot treat this with medication. The mandatory intervention is urgent mechanical hemodialysis to physically scrub the accumulated toxins from the patient's bloodstream. The second suspect in this population is pharmacologic. When a patient with a compromised kidney is given the antibiotic cefepime, the organ fails to clear the drug, resulting in a massive, unintended toxic buildup in the serum. Cefepime toxicity attacks the brain through a different mechanism than uremia. The drug lowers the seizure threshold, specifically triggering myoclonus and non-convulsive status epilepticus. The external presentation is deceptive. The patient appears unresponsibly lethargic, perhaps with minor facial twitching. Internally, however, their brain is locked in a continuous, raging seizure. This Venn diagram maps the diagnostic matrix used to separate these two mimics. Both uremia and cefepime toxicity trigger profound altered mental status in kidney patients, but non-convulsive status epilepticus and high trough levels sit exclusively in the cefepime domain. Because there are no violent convulsions, there is only one diagnostic tool capable of confirming this unseen electrical storm: an immediate EEG. Apply this to a clinical test. An end-stage renal disease patient being treated for pneumonia with cefepime suddenly becomes acutely obtunded and unresponsive. If you assume this is simply worsening uremia and only treat the kidney, you will fail to assess the electrical activity of the brain. You will miss a silent, brain-destroying seizure. Context dictates the diagnostic tool. We turn finally to systemic poisoning. Consider a severely inebriated patient who suddenly crashes into acute metabolic distress, completely unresponsive to standard intoxication protocols. Initial labs reveal the severity of the metabolic distress. The blood work will show a severe high anion gap metabolic acidosis, paired directly with a dangerously elevated osmolar gap. This specific dual gap profile is rare. It points directly to the ingestion of two uniquely toxic alcohols, ethylene glycol and methanol. These chemicals operate through a treacherous metabolic pathway. The alcohols themselves are initially benign. The lethal damage only begins when the liver enzyme alcohol dehydrogenase metabolizes them into highly toxic acids. This flowchart tracks the branching diagnostic logic. Because the labs only alert you to the presence of an alcohol, you must interrogate the specific organ damage to identify the poison. Pathology in the retina isolates methanol, while pathology in the kidney isolates ethylene glycol. Establishing the presence of a dual-gap acidosis narrows the field, but tracking the destruction directly to the specific target organ is the only way to name the exact chemical threat. Methanol has a specific signature of destruction. As it metabolizes into formic acid, it aggressively targets the retina, causing optic disc hyperemia and acute, rapid-onset vision loss. Ethylene glycol, however, attacks an entirely different biological system. When it is metabolized, it converts into a compound called oxalic acid. This initiates massive physical trauma. The oxalic acid precipitates into rigid, envelope-shaped calcium oxalate crystals that physically shred the delicate kidney tubules from the inside, causing acute tubular necrosis and a sudden, catastrophic renal failure. Before dialysis is even considered, both of these poisons require the exact same urgent pharmacological countermeasure, fomepizole. This schematic demonstrates the mechanism of survival. Fomepizole acts as a competitive antagonist, perfectly jamming the alcohol dehydrogenase enzyme. The toxic alcohols can no longer be metabolized and must rebound harmlessly until they are eventually excreted. Apply this logic to a final clinical presentation. An inebriated patient presents with an anion gap of 28, and osmolar gap of 30, and acute, sudden vision loss. Recognizing the distinct visual toxicity of methanol dictates the immediate administration of fomepizole. Mastering these rapid divergence pivot points is the absolute non-negotiable skill required to halt metabolic destruction and save the patient's life.